All right, so uh, next slide, please. So I'm going to be talking about mapping cryptococcal antigeneamia in Nigeria. This is a study we concluded a couple of years back, 2019, we concluded it, and we're in the process of writing it up. Should have been published last year, but COVID-19 happened. So cryptococcal disease, highest risk group is HIV patients, okay? Especially in those with CD4 count less than 100. Although the current guidelines are advocating for less than 200 because it has been reported, increasing rates are now being reported in that group also. And screening also now emphasizes both ART naive and ART positive, ART experience. Next slide, please. So I'll look at a bit of history. We've had some reports on cryptococcal meningitis initially at the beginning. I told you the story of the 36% Indian ink from Jos. That was way back in the 1990s. And then after that, we have this report from 2011. Sorry, that was in 2003, and then 2011, we had this report from Benin City. And then we had a report in 2016 from Lagos, 2015 from Lagos. And after that, we have had a couple of other reports recently. So there's a lot of awareness of cryptococcal meningitis in our setting now. And these are cryptococcal antigeneamias. Next slide, please. So cryptococcal meningitis, I've already told you, is common among the advanced HIV disease population. However, that is not the picture we are seeing from China. China seems to have a lot of cryptococcal meningitis among relatively healthy people. I'm not cryptococcal guilty because I know that's what some of you think of. So it's guilty, but it's not. We're looking at new performance. And then most of the time, if there's no intervention, you most likely have 100% mortality rate. And also mortality is high in settings like ours where fluconazole monotherapy is what will be routinely given. Okay, so mortality at 3 months estimated at about 70%. And even when after rates. The next slide, please. Can we have the next slide, please? Maybe I should share my, okay. So the global distribution of HIV-associated cryptococcal meningitis was done by Rita a couple of years back. I think this was in 2018, she published this paper. And it showed that Nigeria and South Africa were most likely to have the highest cases of cryptococcal meningitis globally. Next slide. Okay, and then when you look at the figures, they estimated that Nigeria will have about 27,000 cases, while South Africa will have about 21,000 cases. And that the risks, the cost of risks as screening, I will talk about this much later, would be much, much lower than that of treatment. The next slide, please. So it has also been demonstrated, well proven in literature by French Gray et al. That showed that CRAG, that's cryptococcal antigen, precedes the development of cryptococcal meningitis by a median of about 22 days. A study from South Africa showed that 25% of their CRAG positive patients developed cryptococcal meningitis within the first year of ART. And still another study from South Africa revealed around 1/10 of asymptomatic CRAG positive patients had subclinical cryptococcal meningitis. So this highlighted the need for routine lumbar puncture being done. So that's why you now see that the current guidelines advocate that for any patient that is blood CRAG positive, you still need to go ahead and do CSF, lumbar puncture, to rule out subclinical cryptococcal meningitis. So this is what the updated guidelines are saying: advanced HIV disease population, screen them. If positive, you go ahead and do the lumbar puncture. If it is positive, you treat as cryptococcal meningitis. If it is not, you give preemptive therapy, and that this reduces overall mortality and is also cost effective. And this has been adapted in a lot of national HIV programs in Botswana, South Africa, Uganda. In principle, we have done that in Nigeria, but it's not been implemented. Next slide, please. The next slide. So in Nigeria, we have about 1.9 million people that live with HIV/AIDS, of which most of this 1.9 people are actually for those within the ages of 15 and 45. So those that fall outside that, you can imagine what it is. And there were an estimated 53,000 deaths, HIV/AIDS related deaths in 2018. And we also discovered that there's considerable regional variation in the HIV prevalence, ranging from 1 to 12.7 across the country. And the WHO Advanced HIV Disease Package of Care, as of earlier, even as of the beginning of this year. So this formed the rationale for a study that the survey that we did, the Cryptococcal Antigeneamia survey that we did. We used a uniform sample size that wanted to use to estimate the burden and distribution of cryptococcal antigenemia across Nigeria. We chose representative sites from the 6 geopolitical zones of the country, and then we identified demographic and clinical factors that could be associated with the likelihood of cryptococcal antigenemia, and then the data generated, we planned, and which we are already doing, using to guide advocacy and implementation of the Advanced HIV Disease Package of Care. The next slide. So we selected 11 ART clinics, like I told you, that represented the 6 geopolitical zones in Nigeria. And you can see the spread here. The next slide, please. So the study population were all advanced HIV disease population as defined by WHO. And all patients were screened regardless of their ART status. As long as they fell within that definition, we screened them. Okay, and then we used the CRAG, CRAG LFA point of care test to do it. And this study was between April 2018 and 2019. And then we used questionnaires to gather clinical and other data. So our results showed that age was a contributing factor, it was significant, and that the people between the ages of 18 to 12, okay, were at greater risk, so they were younger ones, which would have expected to be the opposite, that is the case. And then facility, there was a geographical variation across, so that was still significantly significant, and of course, education was also key. Next slide. Okay, so if you look at this, you can see that the highest rates came from Oyo, okay, that had 12.3, and then places like Adamawa, Yola that was screened had 0, had no cases. Lagos, that is just next to Oyo, gave us 6.3 in only 32 patients that were tested. From Shagamu, we had just 3% of it. And then like that, even Benin City, where they had very high rates before, we had very low rates in this study. The next slide, please. So the total prevalence was 3.9% of CRAG antigenemia. So it shows you that there's geographical variabilities. And even then, one of the questions that come to mind is that, could it also be related to, is there seasonal variation also? Because when we compare this to earlier data, there's a lot of variation. So could there be seasonal variation? That is a lovely study that someone might have to look at and determine. Okay, so clinical characteristic, the CD4 count was critical, and then we also discovered that we had a number of patients that were ART experience, which is supposed to be protective, still having that were crack positive, and a couple actually went on to have the infection. The next slide, please. Emma, can I have the next slide? So the other thing we're also doing in this study is that we are doing a mathematical modeling of the cost of treatment, or cost of screening versus treatment. And the modeling suggests that about 3,650 cryptococcal meningitis cases annually can be averted if we just do crack screening and preemptive therapy. So that's preemptive therapy. $100 to treat one case of cryptococcal meningitis, because you need to give, we base this on the giving liposomal amphotericin B, and that is versus the crack screening that will cost. If you screen, you will spend just $4, and if the patient is positive, you're going to go ahead and treat with fluconazole if CSF is negative. So it's obvious that there's going to be, it's more cost effective, even in the Nigerian setting, to screen than to wait for the infection and treat. We are still working on that model, and the data, that's one of the things that has kept the data for a while now. In conclusion, we showed a high overall burden of cryptococcal antigeneamia, and we showed that there was variability across geopolitical regions, and I also think we might have variability across seasonal variabilities also. And the prevalence of crack was significantly higher in ART naive patients, but half of these crack positives were also ART experienced, which ideally shouldn't be the case. So we are probably looking at treatment failures, or there are some other things, other factors that we need to tease out of this data. So a large proportion of Nigerian AHD patients that are presenting to care are already presenting with overt symptoms of cryptococcal meningitis, because we have quite a number that had headache, and like I said, a number of them proceeded to have cryptococcal meningitis. So this survey provides valuable evidence for the ongoing development, and we've used it for advocacy with the Ministry of Health, and it was part of what we presented before UNITAID to help get us into the package of care implementation, the implementation of package of care in select sites in Nigeria. Okay, and we are also going to prove that screening and preemptive therapy is most likely going to be cost effective. So I'd like to acknowledge my mentor, Professor David Denning, Dr. Tom Chila, who is the CDC division, Mycology division chief, who is my hero. He's supported us as a country, Nigeria, and as MMSN, he has been a bedrock for us. Alex Jordan of the Mycology division, he has worked tirelessly on this program. He was a program supervisor. Bruce Larson is the one developing the economic model, and he plays with figures that don't make sense to me, and he makes them to become sensible. And of course, the crypto study group, I call them the Indomitables. We had some very exceptional people. I would like to, I don't want to call names here because I probably don't end, but I'd like to thank them all. I think I should mention Dr. Yaya from Sokoto. He's been amazing. And of course, Gafi got us the grant. Gafi got us started. Gafi has supported Nigeria all the way. Next slide, please. In my next slide, yes. So on behalf of us in the crypto study group, these are us, the Incredibles, doing incredible things, changing the landscape.